Factitious disorder imposed on self, more widely recognized as Munchausen Syndrome, is a psychological condition where individuals deliberately fabricate or induce physical or psychological symptoms in themselves. These individuals may go to great lengths to simulate or even create real illnesses, injuries, abuse, or trauma with the primary objective of gaining attention, sympathy, or reassurance from others. Munchausen syndrome is a specific type of fictitious disorder characterized by predominantly physical signs and symptoms. However, it is also commonly associated with a pattern of recurrent hospitalizations, frequent travel to different medical facilities, and the telling of dramatic, highly improbable stories about the individual's past experiences. These stories often contain exaggerated or outright fabricated details intended to enhance the perception of the suffering or the complexity of their medical history. The term Munchausen syndrome originates from the name of a fictional character, Baron Munchausen, who is also known for his fantastical and exaggerated tales of adventure. Factitious disorder imposed on self shares a connection with another form of factitious disorder known as factitious disorder imposed on another. In this variant, the individual fabricates or induces symptoms of another person, usually someone under their care, such as a child or less frequently an adult partner. The motivation behind this behavior is similar to elicit attention, sympathy, or reassurance for themselves, but through the suffering of another. This particular form is commonly referred to as Munchausen by proxy. In the cases of Munchausen by proxy, the drive to produce or exaggerate symptoms in the victim can lead to unnecessary and often invasive diagnostic tests and medical procedures which can be both costly and harmful. This condition not only is dangerous for the victim, but also represents a severe form of abuse that requires immediate intervention to protect the victim and address the underlying psychological issues in the perpetrator. In fictitious disorder imposed on self, also referred to as Munchausen syndrome, the affected individual intentionally exaggerates, fabricates, or even induces symptoms of illness within themselves. The primary motivation behind this behavior is to gain medical attention, examination, treatment, and the associated comfort, sympathy, or reassurance from healthcare professionals. This disorder frequently involves elements of victim playing and a strong need for attention. In particularly severe cases, individuals with Munchausen syndrome may possess an extensive knowledge of medical practices, enabling to produce symptoms that could lead to prolonged, expensive, and often unnecessary medical investigations, extended hospitalizations, and even unwarranted surgical procedures. That for those afflicted, assuming the role of a patient provides a sense of familiarity and comfort, fulfilling a deep-seated psychological need. This order is notably different from hypochondriacs and other somatoform disorders, where the individual genuinely believes that they are ill and does not intentionally create or exaggerate their symptoms. Unlike malingering, where the fabrication of symptoms is driven by external incentives such as financial gain, avoidance of work, or access to drugs, those with factitious disorder imposed on self are not motivated by such material benefits, but rather the psychological gratification derived from being in the patient role. The precise cause of fictitious disorder imposed on self remains unknown, but is believed to be a result of complex interplay of biological and psychological factors. Several risk factors have been identified and may predispose an individual to develop this disorder. This includes a history of childhood trauma, such as emotional neglect or abuse, growing up with emotionally unavailable parents or caregivers who are preoccupied with their own illnesses or emotional issues, having experienced a serious illness during childhood, unfulfilled aspirations to work in the medical field, underlying personality disorders, and low self-esteem. More reliable statistics on the prevalence of factitious disorder in the United States are lacking. It is generally believed that the disorder is much more common among mothers who have experienced these factors. Additionally, individuals with a background in healthcare are thought to be at higher risk of developing factitious disorder imposed on self. A variant of this disorder, known as arrhythmogenic Munchausen syndrome, describes individuals who feign or induce cardiac arrhythmias in order to receive medical attention. This variant highlights the lengths of which some individuals may go fabricate or induce symptoms that necessitate extensive medical evaluation and intervention. Factitious disorder imposed on self has a related counterpart known as factitious disorder imposed on another. This condition has been observed in parents or guardians who fabricate or induce medical conditions in their children or, in some cases, in their pets. In these situations, the adult ensures that the child or the pet experiences symptoms that require medical attention, leading to repeated treatments and significantly time spent in hospitals during the child's formative years. In some instances, the parent or guardian may actually initiate the disease in the child. This behavior, while related to Munchausen Syndrome, is considered a distinct condition. There is a growing consensus within the pediatric community that this disorder should be reclassified as medical abuse to underscore the serious harm caused by the deception and to reduce the likelihood that the perpetrator can use a psychiatric defense when the harm becomes apparent. This shift in terminology aims to more accurately reflect the abusive nature of the disorder and the impact it has on its victims, thereby emphasizing the need for appropriate legal and medical intervention. Diagnosing fictitious disorder is notoriously challenging due to the deceptive behaviors exhibited by those affected. Individuals with this disorder often go to great lengths to mimic or create symptoms, making it difficult for healthcare providers to distinguish between genuine medical conditions or fabricated ones. When no clear physical cause is found for the symptoms, the healthcare provider may refer to the individual to a psychiatrist or psychologist, mental health professionals with specialized training in diagnosing and treating psychiatric disorders. These professionals use a combination of detailed patient history, physical examination, laboratory tests, imaging studies, and psychological assessments to thoroughly evaluate the individual's physical and mental health. After an exhaustive review of the person's history and symptoms, a clinical assessment is essential for diagnosing fictitious disorder imposed on self. It is crucial for clinicians to remain vigilant and aware that individuals presenting with symptoms may exaggerate or fabricate details, or that the person reporting on behalf of the patient may do so. Therefore, caution is necessary to ensure that there is substantial evidence before making a diagnosis. To differentiate factitious disorder from other medical conditions, various laboratory tests may be required. These tests might include a complete blood count, a urine toxicology, blood tests to determine drug levels, cultures to identify infections, coagulation tests, thyroid functions assays, or even DNA typing. In some cases, advanced imaging techniques such as CT scans with magnetic resonance imaging along with psychological testing, electroencephalography or electrocardiography may be employed to further evaluate the individual's condition. A comprehensive overview of the more common and reported cases of fictitious disorder, including Munchausen Syndrome, along with the laboratory tests used to differentiate these from actual physical diseases, provides valuable insights for healthcare professionals. This information is critical in guiding clinicians as they navigate through the complex process of diagnosing fictitious disorder, ensuring that the diagnosis is accurate and based on solid evidence. People with factitious disorder may go to extraordinary lengths to fabricate or exaggerate their symptoms, employing various methods to deceive medical professionals. Beyond simply investing past medical histories of faking illnesses, individuals may deliberately harm themselves in a variety of ways to convince clinicians. For example, they might ingest laxative or other harmful substances to induce severe gastrointestinal distress, or may inflict injuries upon themselves such as cutting or bruising to simulate bleeding or other physical symptoms. Additionally, some may alter or tamper with laboratory samples such as contaminating urine or blood tests in order to produce abnormal results that align with fabricated symptoms they claim to experience. The deceptive nature of these actions is further complicated by the fact that many of these conditions these individuals claim to have do not present with clear, observable, or easy diagnosable symptoms. As a result, the syndrome can sometimes go undetected for extended periods. Patients may frequently change their identities or provide false information when visiting different hospitals, making it even more challenging for healthcare providers to recognize a pattern of deceptive behavior. This ability to manipulate the care health system often allows the disorder to remain undiagnosed and untreated. Fictitious disorder carries significant risk and can lead to numerous severe complications. Because individuals with this disorder are often willing to go to the extreme measures to maintain the appearance of illness, they can suffer from various serious health consequences. These can include severe infections, major injuries, or damage to vital organs. In some cases, the lengths that they go to may result in the loss of limbs or permanent disability. Tragically, in the most extreme situations, the self-inflicted harm or the consequences of unnecessary medical procedures can lead to death. The willingness of individuals with fictitious disorder to endure such harm underscores the seriousness of the condition and the critical need for the timely diagnosis and intervention. Due to the inherent challenges in diagnosing and treating suspected fictitious disorder imposed on self, some experts recommend that healthcare providers exhaust all possibilities of an underlying physical illness before making a diagnosis. This approach involves meticulously ruling out the potential presence of an early-stage disease that may not yet fully be apparent. Only after this thorough examination would healthcare providers consider the possibility of fictitious disorder. This may then proceed by taking a detailed patient history and reviewing medical records to identify any signs of early deprivation, child abuse, or pre-existing mental illnesses which could be contributing factors. If there's a concern that the individual may be in danger to themselves due to their behavior, psychiatric hospitalization may be necessary to ensure their safety and provide intensive treatment. In such cases, healthcare providers often collaborate with mental health specialists to address not only the fictitious disorder, but any other psychiatric conditions. This collaboration is crucial to avoid countertransference, where the healthcare provider's feelings towards the patient may interfere with objective care. Treatment strategies typically focuses on managing the underlying psychiatric disorder that may be driving the fictitious behavior. Common co-occurrence disorders may include mood disorders, anxiety disorders, or borderline personality disorder. The success of the treatment and the patient's long-term prognosis largely depends on the nature of the underlying disorder. For instance, mood disorders such as depression and anxiety often respond well to treatments like medication or cognitive behavioral therapy, or CBD for short. These disorders, when properly managed, can lead to significant improvements in the patient's overall condition. On the other hand, borderline personality disorder presents a more complex challenge. Personality disorders are generally considered pervasive and more resistant to change, making them more difficult to treat effectively. Consequently, patients with underlying borderline personality disorders tend to have a less favorable prognosis compared to those with mood or anxiety disorders. The enduring nature of personality disorders often necessitates long-term therapeutic interventions, which may not always yield the desired outcomes. This underscores the importance of early detection and comprehensive treatment planning to improve the chances of better prognosis for individuals with fictitious disorder imposed on self. The term Munchausen Syndrome originates from the name of the Baron Munchausen, a fictional character inspired by real-life German nobleman Hieronymus Karl Friedrich Freiherr von Munchausen. The historical Baron Munchausen gained notoriety in the late 18th century as a captivating storyteller, renowned for his entertaining his dinner guests with outlandish tales of his supposed adventures during the Russo-Turkish War. His stories, often filled with exaggerated or entirely fabricated details, left a lasting impression on those who heard them. In 1785, Rudolf Erich Raspe, a German-born writer and con artist, anonymously published a book that further immortalized the Baron. In this book, Raspe presented a highly fictionalized version of Baron Munchausen, who recounts a series of fantastical and impossible exploits. The character quickly became a literary sensation, embodying the archetype of a bombastic liar and an exaggerator of the highest order. Raspe's portrayal of the Munchausen established the Baron as a symbol of absurdity and grandiose storytelling. Fast forward to 1951, when a British physician, Richard Asher, first identified and described the pattern of behavior in which individuals deliberately harm themselves and fabricated histories, symptoms, and signs of illnesses. Reflecting on the similarities between these individuals' behaviors and the outrageous tales of Baron Munchausen, Asher coined the term Munchausen Syndrome in an article published by the Lancet in February 1951. In his article, Asher made the connection explicit, noting that just like the fictional Baron, those afflicted with this syndrome often claim to have travelled widely and told dramatic yet entirely untruthful stories about their experiences. Asher respectfully dedicated the syndrome to the Baron, thus embedding the name of the medical terminology. The adoption of the term Munchausen syndrome was not without controversy. For nearly 50 years, medical professionals debated the appropriateness of Asher's choice of name. Critics argued that the referencing of a literary figure, particularly one associated with human fantasy, was inappropriate given the consciousness of the disorder. Some objected to the anglicized spelling Munchausen, considering a misrepresentation. Others felt that it was linking the disorder to the real-life Baron Munchausen, who did not suffer for it, was misleading. Additionally, the association with the character was seen as fundamentally ridiculous, was viewed by some disrespectful to patients grappling with the disorder. Originally, the term Munchausen Syndrome was used broadly to describe all factitious disorders. However, with the publication of the DSM-5, the terminology evolved. The names Munchausen Syndrome and Munchausen by proxy has been replaced by the more clinical terms factitious disorder imposed on self and factitious disorder imposed on another, respectively. This shift reflects a move forward to the more precise and respectful language in the diagnosis and treatment of these complex psychological conditions. Munchausen by internet is a term used to describe a specific pattern of behavior seen in individuals with factitious disorder imposed on self, where they feign illnesses or dramatic personal crises in their online communities. This phenomenon was widely recognized in the medical literature as an extension of factitious disorder, where the affected individuals use their anonymity and reach of the internet to gain sympathy, attention, or emotional support by portraying themselves as seriously ill or as victims of violence. The first reports such as deceptive behavior in internet forums emerged in the 1990s, coinciding with the rapid growth of online communication. The term Munchausen by internet was coined in 1998 by psychiatrist Mark Feldman to describe this unique digital manifestation of the disorder. In popular media, the term has also been referred to as cybermunch by New Zealand's PC World magazine, with those engaging in such behaviors such as labelled cybermunchers. These individuals often infiltrate online support groups, which are typically created to provide emotional and practical support in those in need, and exploit the trust and goodwill of the members. Some experts speculate that the reason these individuals choose online forums over traditional healthcare settings is due to limited time, extensive medical knowledge, and inherent skepticism of healthcare professionals who may be less likely to provide the level of emotional engagement these individuals seek. Anonymity offered in the internet is believed to play a significant role in enabling this type of deception. As Steve Jones discussed in an article published in The Guardian, the lack of two-faced interaction in online setting makes it easier for individuals to fabricate stories without being detected. Since online interactions have only been possible since the 1980s, the increasing prevalence of this behavior has been relatively recent development. When individuals engaging in Munchausen by internet are exposed, the consequences within the online communities can be severe. Those who are discovered to have faked their illness or traumatic experiences are often banned from the forums where they perpetrated this deception. However, because there was usually no exchange of money or clear violation of laws, there are few legal consequences for these actions. The lack of recourse leaves the affected communities to deal with the emotional fallout of their own. The exposure of such fabrications often leads to intense polarization within the online community. Some members feel embarrassed or ashamed for having believed their elaborate lies, while others may continue to support the deceiver, refusing to believe the truth. Mark Feldman also noted, in some of the more extreme cases, there have been an element of sadism involved, where the perpetrator takes pleasure in the distress caused by the deception. In response to such scandals, some perpetrators may react by accusing others of dishonesty, further disrupting the community. To prevent ongoing negativity, many support groups chose to ban discussions about the fraudulent individual altogether. Unfortunately, the damage is done by these incidences and is often irreversible, leading to the splintering or even closure of once thriving online forums. An interesting example of impact of Munchausen by internet can be found in a forum created by members of the blog hosting service LiveJournal in 2004. The forum was dedicated to investigating the cases of reporting deaths within online communities. In 2007, the LiveJournal forum revealed that only about 10% of the reported deaths were genuine, highlighting the prevalence of deception in online spaces. In conclusion, Munchausen Syndrome is perhaps one of the greatest real-life horror stories that anyone could experience. This is why empathy is key, and this is why we need to do a lot more screenings for mental health, because this can affect absolutely everyone, and it's damn scary as well. If you like this video, subscribe, like, do all the things, and
See you in the next video.